Hi, this is Dr. Nick with the ECG Academy, and we'll finish our discussion of interventricular conduction disturbances. I want you to understand a little bit about the action potential of the heart. Remember, if you take a heart muscle cell and you measure the inside of the cell using a little tiny tube, you can determine that the inside of the cell starts out being more negative. As you can see, the resting membrane potential is somewhere around minus 80 millivolts. And then with the action potential going through the different phases, the upstroke is known as phase 0, and then it comes down a little bit, which is phase 1. The plateau phase is 2, and the repolarization is phase 3. This is basically movement of sodium into the cell, which makes the inside of the cell more positive. And then repolarization is potassium that rushes out of the cell, and that happens during phase 3, which brings the cell back to its resting membrane potential, which is more negative on the inside. Okay, well, that's just a quick review, but there's something we haven't discussed, and that has to do with excitability of the cell. So if a neighboring cell is over here, and they're connected to each other with these gap junctions that allow movement of sodium and potassium across the cell from one cell to another. Now, at what point can a cell respond to an outside stimulation? At what point can this cell fire because of a neighboring cell's action potential? Well, certainly during the resting phase, when it's down here at minus 80 millivolts, it's very excitable, and that's what brings the action potential sequence about is a neighboring cell. But you can't stimulate the cell again midway through the cycle. The sodium channels just aren't ready. And so at what point along the action potential is the cell able to receive another signal from a neighboring cell and fire again? And it has a lot to do with the membrane potential. That membrane potential has to come down almost down back to baseline. Under certain circumstances, it can fire a second time before it's gone all the way back down to its resting membrane potential, and it has to do with resetting of these sodium channels. But there's a certain period of time where the cell is not excitable, where the cell cannot fire a second time, and that period of time is known as the refractory period. All right, now this is getting into some advanced physiology, and I'm going to go over this in more detail in the videos that I'll do in the advanced course. But this refractory period is well defined under most circumstances, and it's the time where the cell is not excitable. It will not fire. Tissues can be refractory as well, including the bundle branches. So think of it this way. As the AV node sends a signal down the bundle branches, and this results in a QRS complex, there's a certain period of time after that beat where the bundle branches are incapable of accepting another signal. They are refractory. Well, it turns out that the bundle branches are not completely homogeneous in that one bundle may in fact recover a split second before the other bundle. What that means is if you look at the action potential of the cells of the right bundle branch and you compare the action potentials of the cells of the left bundle branch, the left bundle branch action potential duration may be a little shorter and the refractory period is a little bit shorter. What that means is if the AV node lets a signal down at this point in time following the last beat, that the left bundle may be able to conduct it because its refractory period is over, but the right bundle is still refractory. So what will happen is that the beat will get to the ventricles, but the right bundle will be blocked for that one beat. And as a result, you'll get a widened QRS because of a bundle branch block type of IVCD, and this is known as functional aberrancy. Aberrant conduction simply means that the signal took an abnormal path. Aberrant sort of means abnormal. And if the signal takes an abnormal path because one of the bundles is blocked, then that gives rise to a widening of the QRS complex. But the fact is that the right bundle is still capable of conducting, that it's not really truly blocked, but it acted as if it was blocked because of the way it was functioning. Okay, so that's where we get the name functional bundle branch block or functional aberrancy or functional IVCD, okay? Now here's an example of a rhythm strip, and we look at the forest and we see these 3 beats here. The one thing that you should notice right off the bat is, well, first of all, the beats look to be fairly regular, and the QRS complex looks fairly wide. In fact, this starts about 20 milliseconds before the heavy line, and it finishes after 3 small boxes, so we're talking about 140 milliseconds worth of QRS complex, which is pretty consistent. We can see a very vague-looking P wave in front of every beat, and the PR interval, if the QRS complex starts here and the P wave starts about here, we're talking about maybe 200 or 210 milliseconds of a PR interval. So we have a first-degree AV block, and we also have this wide QRS complex, which could very well be a bundle branch block. Now, it's hard to diagnose a bundle branch block just based on a rhythm strip, but clearly there's some aberrant conduction going on. The QRS is wide, so there is some kind of interventricular conduction disturbance. When I show you the whole strip, you'll see that we were looking at AVF here, but the QRS complex is very wide and bizarre in all leads, with the rabbit ear appearance in 1 and AVL, and this very deep S wave and a widening of the QRS complex. So this is pretty typical for a left bundle branch block pattern. In the intermediate 12-lead class, we're going to go over exactly how you diagnose the different types of bundle branch blocks. But for this basic class, just understand that widening of the QRS indicates some kind of interventricular conduction delay or aberrant conduction. Well, the point I want to get across in this video is that aberrant conduction is not always consistent, and that you can have functional aberrancies, and when you're looking at a rhythm strip like this and you scan across, you can see there is some irregularity to this QRS complex. Each QRS complex seems to start with a P wave. There's one there and there's one there, and you can see it's very irregular because there's a pause over here. Okay, but what you also notice is that some of the QRS complexes look very narrow, like this one is narrow and this one is narrow, and so is this one and this one. And by narrow, I'm talking about 80 milliseconds or so. But these 2 beats appear to be significantly wider, somewhere on the order of about 140 to 160 milliseconds. How does the PR interval compare? I've magnified this picture a little bit, and I put these little teeny tiny calipers on. But if you look at the P wave of the narrow beat and compare it with the P wave of the wide-looking beat, it doesn't seem to change. Let's go to the narrow beat following the pause, and in fact it looks a little bit shorter. So if you measure the PR very carefully, you'll find that the PR is certainly in the normal range, regardless of whether the QRS is narrow or wide. And so you're not dealing with an AV nodal problem, and these are not ventricular premature beats, which we're going to talk about in the next section. But these are conducted beats down the AV node, but they're wider than the normal beats, and so they are aberrantly conducted. Well, why are they aberrant? Well, let's bring up another pair of calipers and see. If you look at this aberrant beat compared with the prior QRS complex, okay, and let's look at the coupling interval, in other words, how far apart from the last QRS complex we see, we're talking 2, 4, 6, 8, about 900 milliseconds. So that's a little bit faster than 60 beats per minute. But so we have 900 millisecond coupling interval, and let's look at this beat over here. It's about the same, maybe 920. Then, of course, you have a much larger interval from here to here, and a much longer interval from here to here. And now let's look at this interval from one narrow beat to the next. See, it's a little bit longer than 900. It's more like 1100. And so what we can assume from this tracing is that there is a bundle branch aberrancy that occurs when the QRS complexes are 900 milliseconds apart, but not when it's greater. You see, this is the pause that refreshes. So with this time interval, both bundles have a chance to recover, and so this QRS complex conducts in a narrow fashion down both bundles. And so does this one, because you've got lots of time here for both bundles to recover, and this one, being 1100 milliseconds, conducts normally as well. But here when you have 900 and here you have 900, that's not enough time for both bundles to recover. So one bundle gets blocked and the QRS becomes wide. And this concept of a rate-related bundle branch block is going to become very important when you start talking about distinguishing supraventricular tachycardia with aberrant conduction from ventricular tachycardia, which is a topic that we'll touch on at the end of the basic course, but we'll spend much more time in the intermediate and the advanced courses. But the idea that the bundle branches may not be blocked all the time, that they're only blocked under certain circumstances, is known as this functional IVCD, and that's the point of this video, is that aberrant conduction may come and go, depending upon the circumstances. Here's another example. This is the first time I'm going to teach you this thing, is that you should never ever pay attention to what's written on a rhythm strip, because chances are the person who interpreted the strip was not an ECG expert. But since you're watching this video, it seems that you want to be, okay? And that's my job, is to get you guys to be really good at looking at these tracings. So what do we see in this tracing? Well, we see a somewhat of an irregular heartbeat. Scanning across, you can see it's kind of slow over here, and then it sort of speeds up, and it gets very fast. Here the heart rate approaches about 120 or 130 beats per minute, and then it suddenly slows down again. Now, what exactly happens with the QRS complexes? The QRS complexes are a little bit wide to start with. They're just about 120 milliseconds here. And your PR interval is somewhat long as well. It's about 220. So you have a little first degree AV block in the beginning, and you have a slight IVCD here. But then what happens is the QRS complex changes. It starts to look different. Where are the P waves, though? You see, if you scan across and looking for bumps, and here's a P that precedes this QRS complex. And then if you look across, here's the next P that seems to conduct to that. But why did this QRS change? Why did this QRS look a little bit different? And if you look at this run here of a rapid rhythm, you see that there's a P wave in front of every single beat. That tells you that basically the atrium is driving the ventricle, but yet the QRS is changing. This is another example of functional aberrancy. Even though the QRS starts out a little bit wide and stays kind of wide, it changes. It looks different. The idea that this QRS complex looks different than this QRS complex was misinterpreted as evidence that these were ventricular beats, and that's why they called them PVCs, or premature ventricular contractions. They even called it a run of VTAC. But clearly you can see there are P waves in front of every beat. So this is an atrial arrhythmia with aberrant conduction that caused the QRS complex to change in its shape and size. Okay, so aberrant conduction doesn't always mean that the QRS gets wide. Sometimes the QRS complex doesn't really seem to change its duration. It just looks different because what's happening is you're getting detours of signals going around the back door somehow. Some of the bundles are conducting, some perhaps not. Some of the Purkinje system is refractory and some of it's not. This clearly looks like a rate-related aberrancy, but in this case the QRS duration didn't really change much. Just understand that aberrant conduction means the QRS was inscribed different from normal. That doesn't always translate to wide. Here it was wide to start with, and then it just sort of like changed its shape. Sort of an advanced concept, just something that I want to mention at this point in time, but I'm definitely going to cover this again and again in future videos because it's a very important concept to understand. Now here's one last strip that I want to just throw at you. This could easily make a nice chalk talk. I want you to examine this strip carefully, and it's actually kind of a tough one, but I wanted you to see how the QRS in these 3 beats looks different than these 3 beats. This QRS is clearly wide. It goes from this box to a little over this heavy line. It's about 170 milliseconds, and that's pretty consistent here. You got a little more than 4 boxes wide in all these beats. So you have some kind of underlying bundle branch block pattern here, some sort of IVCD that's present, but then the QRS gets even wider on these beats. In fact, this is over 200 milliseconds in duration. But I wanted you to notice something. This little teeny tiny black mark right there before the QRS starts, right there. And then you see it again here. Well, you know what that is? It's a pacemaker spike. And that's one of the things that I touched on in the last video. When a patient has a pacemaker, you'll see very wide QRS complexes because the electrical signal has to move very slowly through the left ventricle. This is not a paced beat because pacemakers are machines. They're electronic clocks. And if we take our calipers, we can see that this would be the interval from one pacing spike to the next. And so you'd expect the next pacing spike to land here. So this beat clearly came early. It's even more wide and bizarre than the underlying beat. And this is actually a premature beat, a premature ventricular contraction, which is wide and bizarre because it arose from the ventricles and did not take the normal conduction. If you think that's a little confusing, it'll all become clear in the next section when I'm going to start talking about premature beats, including atrial and ventricular premature contractions. And then I'll circle around and talk about atrial premature beats with aberrant conduction to, in essence, complete this discussion of functional aberrancy. And so, this is Dr. Nick for the ECG Academy. Thanks for watching.